Welcome, everyone. I think everyone's mostly connected to audio by this point, so I'm going to get started. My name is Lauren Tobias, and I'm filling in for Dr. Tapa to moderate today's sleep seminar. I have a few quick announcements before I introduce our speaker. In order to receive CME credit for attendance, please see the chat room for instructions. You can text the ID for this conference anytime until 3:15 Eastern Time. And if you're not already registered for Yale CME, then you will need to do that first. If you have any questions throughout the presentation, I encourage you to make use of the chat room throughout the hour. And we will also have some time at the end for folks to unmute themselves and ask questions aloud. And actually, I was just told before this that you are not able to unmute yourself. So actually, if you could just raise your hand or put a chat comment, I can unmute you. And then finally, please feel free to pass on the announcements for these lectures that you get from Debbie Lovejoy to anyone else who you think may be interested. We'd love to expand our email list and get the word out about these great talks. So now I am delighted to introduce Dr. Sreelatha Naik. Dr. Naik received her bachelor's degree in biomedical engineering before going on to do her MD and internal medicine training at Rutgers. We were fortunate to recruit her here to Yale for her pulmonary critical care fellowship, during which she completed a research project with Mayor Krieger related to remote monitoring of CPAP in the veteran population. And then she went on to do a sleep fellowship at Beth Israel Deaconess Medical Center and Harvard Medical School, and ultimately an attending position at Geisinger Health System in Pennsylvania. Dr. Naik is currently director of the sleep medicine program at Geisinger and program director for their sleep fellowship, which she founded. She has received funding from the Geisinger Clinic Research Fund for several projects related to hypercapnic respiratory and failure in patients with COPD, to the assessment of sleep in the inpatient setting, and also pulmonary issues such as treatment of COVID patients. Dr. Naik has been involved with leadership at a national level as well. She currently serves as vice chair of the American College of Chest Physicians Respiratory-Related Sleep Disorders section of the Sleep Network, and she's on the editorial board for Chest Physician. Her particular area of sleep expertise centers on the use of non-invasive ventilation as it's related to the various hypoventilation syndromes. And having known her myself since we were co-fellows here at Yale several years ago, I can say that on an interpersonal level, Dr. Naik is one of the most authentic individuals that you'll ever meet. She's an enthusiastic and dedicated educator with fresh ideas for medical education, and she's a superb clinician. So it is my great pleasure to welcome her this afternoon to give a talk entitled Breathing Against the Odds, Navigating Home Mechanical Ventilation Through Bob's COPD Journey. Please join me in welcoming her, and I will turn it over to you.
Awesome. Thank you very much, for such a great introduction, Dr. Tobias. It is, I am learning that I probably should do this more because I feel I can't have another forum where so many nice things are said about you as I guess an introduction to the Grand Rounds. So thank you for having me here. I wanted to start first by saying thank you for having me here, but thank you for training me. I see some colleagues and mentors and Dr. Krieger present here, a mentor for life, and can't thank all of the learning from the folks here and that have contributed to my being a doctor right now. And so this is really an ode. This presentation is an ode to some additional teachers we all come across who are our patients. And so I wanted to first bring up this disclosure. Everyone will get a CME credit for it. You get a CME. And please text this number to receive your CME code for participation. I had one a conflict with a company, but the relationship has ended. Okay, so I'll first talk about our patient. He is a 54-year-old man. I'm going to move my window over here so I can see my own slides. 54-year-old man with a history of very severe COPD, FEV1 of 12%. He had been followed in our clinic for many years in pulmonary medicine and formerly smoked 2 packs a day from when he was 14 till about 34, and then he quit about 20 years ago. He wasn't someone who exacerbated frequently, but one year in 2021, things were really bad. And he had a severe exacerbation and was hospitalized in an outside center and was intubated, extubated, and then ultimately transitioned to an LTAC because he required high intensity, non-invasive, long duration of non-invasive ventilation. And so, unfortunately, after he arrived at the LTAC, he had recurrent respiratory failure, very protracted course, couldn't be extubated, and so ultimately had tracheostomy. And Bob could not wean off the ventilator even at the LTAC and had the trach. He was given two options. He could go home with the ventilator, his family could train with it, or he could seek hospice care. And so he reached out to his pulmonologist, whom he had seen, and requested follow up in our home ventilator clinic. And that's how we met Bob. And this was his road to recovery. And so here's Bob, but he was not alone this time. He came to us with a trach event and some O2. We needed chronic vent management, ultimate decannulation if that was in his future, tracheostomy management. He needed to work on his speech and swallowing again, pulmonary rehab, and management of his exacerbations. And while we as the care team were there for him, he was also not alone at home. He had 5 children, or he has 5 children and a wife. And so they were all with him. And so, this was hard, right? It is not something we do in fellowship. And so I wondered, as our team was taking care of Bob, how did he even get here? This very young guy, so sick with severe COPD, chronic hypercapnia, was not treated before, and now with an intubation after his first real bad COPD exacerbation. And, what could we have done to prevent this? And, I ultimately worked to decannulate him. And, do I need a sleep study? How do I go about this? How do I manage him? There are unfortunately no books written on a clear path for this. And, what settings am I going to choose on his ventilator? And what am I monitoring? And so for management of Bob's out there, I thought we could talk about the pathophysiology and the impact of NIV and COPD, but just wanted to focus very little time on that and more so focus on device settings and devices themselves and a small portion on monitoring outcomes and what else is new and exciting. So how did Bob get so bad? So as I was learning, over the years about this topic, I turned to, I'm going to move my window here so you can see my slides better, many review articles, and I'll cite one here written by, Dr. Tobias as well. So COPD is the third leading cause of death worldwide. There's progressive airflow limitation, and this can ultimately lead to hypercapnia. And 30 to 50% of patients that have very severe COPD do have, hypercapnic respiratory failure, while some patients with even moderate COPD may have hypercapnia. And it's an independent predictor for mortality as well as hospital admission. The mechanisms leading to hypercapnia, and this is, an article Dr. Tobias contributed to here. There's progressive inflammation that ultimately leads to that expiratory airflow limitation. And this air trapping, because of incomplete emptying, it leads to a buildup of volume and pressure at the end of expiration, leading to what's termed this intrinsic PEEP or auto PEEP. And it creates a burden for patients to have to breathe over and have greater effort to be able to initiate inspiration. The diaphragm is also stretched beyond, because it's so air trapped, it's stretched beyond its optimal positioning. And so it's harder for the diaphragm to function. And there's limited time for inspiration because we're spending so much time with, with expiration. And so there's, in addition to the direct mechanics that are altered in breathing, there's also an altered hypercapnic and hypoxic ventilatory response. And This graphic here shows how in our terminal bronchioles and our terminal airways prior to getting to the alveoli, when there's a normal airway, this is what it looks like. But really, when we have hyperinflation, it can cause kind of dynamic collapse of these terminal airways, further worsening, in a cyclic manner, the trapping there. Features that predict hypercapnia, are current smoking status, low FEV1, BMI, and there's some conflicting evidence at the extremes of higher BMIs as well as low BMIs being associated with hypercapnia, as well as a high bicarbonate, which is seen in multiple studies. And so initial studies that studied low intensity non-invasive ventilation really showed no benefit, and we'll review some of them. But high intensity non-invasive ventilation has now been shown to have some benefit. So show me the evidence, right? And so we'll first start with the rescue trial, which was a negative study, where patients that were admitted with acute hypercapnic respiratory failure were initiated on an NIV for more long-term upon hospital discharge after 48 hours after coming off of either invasive or non-invasive ventilatory support. And what we see is that, there's when we look at whether we look at the time to recurrent event or the survival time, there's really no difference across this x-axis of proportion of patients surviving along this y-axis in NIV or standard treatment, NIV being in black and gray being the standard treatment. And so, two other studies, the first one here by Conline and group that was published the same year as the rescue trial, did, however, show some impact. And the difference in this patient population was that these were stable outpatients, and so not after an acute hospitalization. And what we see is that when we look over the time here on the x-axis of 400 days, there is a improvement in the cumulative mortality seen here on the y-axis, with improved with intervention in the red here, as opposed to relative to the control in the blue. A subsequent study by Murphy and group, the HOT HMV trial, as it's called, took post-acute patients similar to the patient population in the rescue trial, but these patients were not 48 hours, but these patients were really a good 2 to 4 weeks after exacerbation upon reaching more stability. But really that inpatient admission it presented an opportunity to identify these high-risk population. And so what they found is that over time, patients treated with home oxygen alone in yellow had lower survivorship relative to patients that were on home oxygen plus NIV. And the time to readmission was also reduced, but keeping in mind that in both of these studies, there was some features that were important were that they used high intensity NIV. The average pressures in this particular study were 24/4. And there was also the target of improving hypercapnia. And so keeping these things in mind, the current ATS guidelines that were published in 2020 recommend the use of NIV in stable hypercapnic COPD. Specifically, the ATS guidelines recommend a threshold of 45, which differs considerably from the payer threshold. And they did recommend that you should undergo screening for sleep apnea, but it could be clinical, that you did not need a formal sleep study. They recommend avoiding initiating NIV for at least 2 to 4 weeks, taking, following the pathway that was in the HOT HMV trial. They did not recommend using the sleep lab to initiate NIV, and they recommended the treatment outcome being normalization of CO2. So, we see this great data with NIV. So why aren't we putting every patient on NIV? And this is where I was when I started out as a new attending. The data was just published after my boards, and I was like, all right, this is great. And I started to kind of capture patients from the inpatient episode after an inpatient episode into our clinic. But I found myself really like overbooking my patients repeatedly. So, I needed to understand how big the scope of the problem was in our system. And so we looked at our own systems data over a 6-year period between 2014 and 2020. And we wanted to have a pure population of like real COPD. And so, and particularly COPD exacerbation. And so we had about 140,900 and a little over 140,000 patients. And we looked at patients that had an abnormal obstructive index with an FEV1, FVC less than 70. All our patients had to have a blood gas, an arterial blood gas within the first 24 hours of admission. And also were treated with steroids so that we capture the exacerbation patients as opposed to stable COPD. And we found that there were about 5,606 such encounters. And of these patients, about 50% had hypercapnic respiratory failure, so about 2,800 hypercapnic patients. And, we knew that there would be this mortality benefit. And our cohort only had, this same cohort only had about 10% of patients being diagnosed with OSA as a diagnosis. So we went by ICD-10 code and not sleep studies. So there's also an underdiagnosis of OSA in these patients, whereas most other studies show a prevalence of about 50% of patients that are admitted for COPD exacerbation have OSA. And so, I know if I go to, my boss here, my leaders here, and mentors, Dr. Sharma, Krista Lucas, they will say, Sri, what do you need to be able to see these patients? What's the staffing? And, really thinking about the patient population, the number of follow-up visits they would require, at least 3 per year, in addition to a new patient visit. I would need like 6 full-time physicians who don't do critical care, don't do sleep, they go on vacation sometimes, but all they do is clinic and manage these patients, which is a challenging model to build, right? So what was actually happening to these patients is that they would come into the hospital, like John Doe here with hypercapnia, and we upfront spend a lot of money investing in these patients to get them through the critical illness and then refer them to pulmonary clinic where they're seen we have what are called COPD discharge visits through a process called proven care COPD. And so we capture them in clinic and, we tweak their inhalers and then maybe they're sent to sleep medicine. And some parts of the country, and including our own early on and many years ago, it used to take 2 to 3 months even to get into sleep clinic. And, this is now not an issue, but sleep testing in the lab is an issue. And if you have a sick COPD patient, you're testing them in the lab. And there's this bounce around between sleep clinic, pulmonary clinic, sleep lab, patients returning to sleep clinic because they don't have sleep apnea for further discussion, or perhaps they make a stop at pulmonary clinic first. And ultimately, the patient may be prescribed either by the pulmonologist or a sleep physician, an IV. And if it's chosen at suboptimal levels like 12/5, we're not really getting at the meat of the problem or the tofu at a problem because, I'm vegetarian. We're not getting there. Thank you, Dr. Krieger. I saw that smirk. And, and we're not really getting at a solution for the patient. And all this while with the delays in initiation of therapy, these patients could be dead or readmitted. And so this is why it's important that all sleep physicians, as well as pulmonologists, clinicians are familiar with NIV and, how we can get these things started. And so we created a pathway and as recommended by ATS where, after an exacerbation, an arterial blood gas would be done in the inpatient setting within the first 48 hours really of admission. Is what the grace period we gave people. And we would then bring them into clinic 2 to 4 weeks later. And if their CO2 remained high, we would initiate an IV and still learning about the problem. And then, also added this other arm where we test people or screen people, have the COPD navigators use the stop bang score, to identify patients that may benefit from sleep medicine referral. The reason we prioritize respiratory failure is because these patients die faster. So to any rate, we looked at like what happens to these patients and, what am I going to tell my boss about the type of clinic that I want to build or ultimately grow into, right? And so, so we took the patients that were normal, took the patients that were referred to our clinic, and I share here the first several months of our data. And what we found is that, there were patients that were either normocapnic or hypercapnic, as we would call them. We're not treating them if they're low, and we're treating them if the payer threshold for initiation of NIV was met. And we looked at, what percent of these patients remained hypercapnic. And we still saw that about 48.9% of these patients remained hypercapnic. And the ones that remained hypercapnic had a lower BMI, and their FEV1 was lower. And there were some additional features as well. But in this particular case, and it's a small sample, so please don't make any judgments here. But this allowed me to kind of predict what population we're looking at. And another thing it allowed us to do was looking at, there's this in-betweeny group that my former trainee and colleague, Dr. Tejwani, likes to call the intercapnic group, where they're above the ATS threshold, but below the CMS or payer threshold for NIV. And there was this intercapnic group where we found that we would tell them you don't need NIV, and they would still get frequently hospitalized. And so we've just kind of been watching this subgroup of patients as well. More data at another time. But, this is all about like, why wasn't Bob being cared for, right? Because I need to get to the bottom of this. And, maybe if I just create a process where I only have the hypercapnic patients like triaged by the navigator, I could only see the ones that are going to be hypercapnic. Forget the intercapnics, which, are also high risk, but they'll be seen by general pulmonologists, right? Or other sleep physicians. And so maybe I need just half as many physicians to do that, but they would still be doing full-time management of these patients with hypercapnic respiratory failure. And this is why the population size is being so high. This is why our patients remain so undercaptured. So, when we're starting NIV for these patients, what are things to consider? So a key point in the ATS guidelines is that the use of high intensity NIV in these patients. So what is high intensity NIV? Please pardon me. I'm just going to check the chat to make sure no one's like asking things, unless Lauren, you like tap me.
You're good for the moment. I'll let you know.
Oh, thanks so much. Okay, so high intensity NIV usually refers to high amounts of IPAP, but really, is it that threshold of 18 that some authors talk about? Is it more? And how do we individualize it to each patient is what I hope we can talk about, right? And ultimately, the goal is to either normalize carbon dioxide, getting to, or reducing it by at least 20% from baseline. And many authors talk about ensuring the tidal volumes at least 8 cc per kilo. Some articles target 6 cc per kilo of predicted body weight, and also ensuring that there's adequate ventilatory rest, which is very, very tricky. Some people talk about maybe looking at the number of percent of patient triggered breaths, which you'll find is very tricky in COPD patients as opposed to neuromuscular patients. And we'll talk about why. So first, what do we mean by high intensity? So when we look at a summary of studies that have been done in this realm, over the years, there's been a wide difference in the type of pressures that have been utilized. So when we look at the hot HMV trial that we reviewed the data for, they used 24/4, but even the rescue trial, 19/5 was utilized. A key difference between these two studies was the timing when it was initiated. In the Conline study as well, again, high intensity pressure was used. There are scenarios where like this McAvoy study, they used 13/5, and I want to say their unadjusted model did have a mortality benefit, but their like risk factor adjusted model did not have a mortality benefit with that low pressure. So maybe it was starting to get a signal, but it didn't quite. So when we look at the studies over the years, all of these various ones, we've migrated to higher and higher pressures. And perhaps this is why we're seeing the benefit, is why these pressures are recommended. You'll notice that some of our patients, some of these studies even used an IPAP of 30. And I certainly have had that experience, like patients, we set a range, particularly on more advanced devices, of not a fixed IPAP, but a range of IPAP. And patients that start off on an IPAP of 30, they get an exacerbation. They're then needing much higher. And if their device can't support them, this is where we run into trouble. And so when we're choosing devices, when we're choosing settings, pardon, there are so many things out there in the market. I haven't listed all the ventilators here. And in fact, some of the studies we'll discuss later on with the ventilators, some of the brands are not even available in the US. Same with the smaller NIV devices, which whether they're bi-level devices or if they're more VAPS capable, more advanced capabilities, some of the devices that have more advanced features are not available in the US, which is really sad, and limits our choices of, either choosing a dinky device that is not going to do what your patient needs, or paying like for the Cadillac, or the Tesla, whatever's popular right now. Um, so advantages of NIV devices are that they need to be plugged into the power source all the time, much like our PAP devices. And there is cloud access for most of them at this point. And then they're cheaper, and they also have a limited number of modes, but they do have modes. They're not just CPAP or bi-level or VAPS. They have different. I think I included that. Some have VAPS modes and, pressure support mode, which can have VAPS within it as well. Pressure control, they can have pressure control modes as well, in addition to bi-level modes. The HMV devices have battery backup. Now almost, I'm trying to think, one of the ones on the 5 that I listed, almost all of them, have it, unless you have like an older LTV. Everything's on a cloud, at least that the DME can pull for us now. They're portable, they have battery backup, and my neck of the woods, I have to think about what happens to people when their power dies. And so that's available. They all have auto EPAP capability, whereas devices in Europe, these other VAPS devices do have auto EPAP capability, which we do not, and that's really sad. A major thing for me in kind of rural, like northeastern Pennsylvania, is that there are no facilities that accept these devices in a nursing home. Despite, you can go out and educate them with staff attrition and turnover and contracts they have to obtain. So, you can say the best device for my patient, and we could be passionate as physicians, is this fancy device because they need a pressure that's really high. And so, but it becomes a huge disposition issue, contributing to increased length of stay and patient dissatisfaction while they're hanging out in the hospital and not getting the rehab they need to be able to ultimately go home. And so it's really important that we are not only able to choose the devices that the studies tell us and the guidelines are able to tell us, but that, what's going to work for our patients in the real world that have limited experience, and they need to be able to breathe, as simply as Bob. And we need to not only think about payer guidelines and clinical guidelines, but I guess nursing home and the patient's life. Um, and so CMS reimbursement, many of us here know that bi-level devices, the CO2 needs to be greater than 52, and we have to have a nocturnal oximetry showing hypoxemia. And we also need to rule out obstructive sleep apnea, which does not have to be through a sleep study. And a lot of clinicians use a threshold of at least a BMI of 35, because we're going to have them on a device anyway. And, I have found with my local DME companies that I have to always have the statement that CPAP was considered and not appropriate, to really prove that they have no sleep apnea. And then, but really it's bi-level S devices that these patients are able to get. And, you have to have the use for at least a few months and show that there's persistent hypercapnia. And this is wrong. This shouldn't say 2 liters. It should be on the EO470 or the bi-level S device. So please pardon me for the mistake here. And so then, if you get this advanced device, qualified, I don't know why anyone would choose anything other than a VAPS device. It's like, it's, I'm trying to, my gosh, invoke my TikTok marketing here. If you're not getting this blush, what are you even doing, is what the influencers say. And so if you're not even getting an ST with VAPS, what are we even doing? And then the vent devices, they're very inconsistent criteria, and a lot depends on our individual relationships with and conversations with our DMEs. And I've had some DMEs ask for us to order a vent when the CO2 is normal, and it just becomes like, what am I even treating? In COPD, I mean, neuromuscular disease, a whole other world, but documentation of high risk of mortality seems to be a consistent feature. But there are some advocacy groups that are working to have more petition CMS for more consistent, payer guidelines here. So these devices, what are the settings we're choosing? So first, I wanted to lay out, what are the features in these devices? And there was just only, because this could be a very long topic, and it's super fun, so we could get lost in it. I thought maybe we could just we talked about the high intensity piece of where we choose our IPAP. I thought we could focus a lot on the EPAP and some of the other things here, and also the dangers of NIV, something that we should think about down the road. And so I thought maybe we could start with what features are available on each device. So with the bilevel S devices, which are first go-to if you have a patient that routine COPD patient that after discharge we're seeing them for the first time, not just at high risk of dying right the second. We might choose this device, particularly if their nocturnal oximetry is abnormal, and the maximum pressure for these devices can go to 25. A lot of my patients need higher pressure than this, and so they tend to have partial treatment, but then, if we check a NOCOX in a couple months, we're then able to perhaps get these more advanced devices, the bilevel ST. But, these bilevel ST devices, they tend to have like a high EPAP. You can go to a device, and I'm trying to stay away from brand names, but there are some devices capable of going up to 30 for the ST device. There are VAPS devices that with technically the same code. So theoretically, we should be able to get them with these same criteria, and I certainly have. And you can set like essentially an IPAP min and max or a pressure support min and max to get us to an IPAP and an EPAP. And we can set a respiratory rate, an inspiratory time, trigger and cycle sensitivities. The tidal volume is assured unless you have a certain brand of device which focuses on alveolar ventilation. And the max pressure can be 30 and even be 40. There's one particular device that, we utilize for patients that are going to nursing homes. And if it's okay, I'll use the brand name. It's the Stellar device, is capable of going to 40. Now, some of the Stellar devices are considered vents and some are not. But I would, of course, ask for this one because once they're on a vent, all of a sudden the nursing home will freak out. And then there's like the vents themselves. So we have, what's nice is unfortunately, because we're in the US, for us to have an auto EPAP, we need to have a vent to be able to do it. And, has all of these features that our lower scale devices can do. And these pressures can get very high. They have battery backup. And if your patient ever ends up on an invasive vent, you can still utilize it. I just want to make sure I'm not missing anything on this slide. Okay, perfect. And in terms of selection, device selection, there is a group that is advocating for the ONMAP TAP, the technical expert panel that is a multi-society kind of advocacy group that has been petitioning Medicare. And these were some recommendations they had published for CMS in how we select NIV versus HMV devices, really referring to anything that's not a ventilator in the realm of bilevel devices as NIV. And what they had recommended was that, maybe we start with bilevel with a backup rate because it gives us so much more capacity. And most of the studies that have been done in COPD, respiratory failure, have been using devices with a backup rate. And so they recommend this as the first line. And if the patient is adherent to therapy and, we evaluate them after and we meet all the treatment goals that we want for the patient, we just leave them alone. And, consider using if they require use during the daytime, so these are higher utilization of the same device, their pressures are high, like many of our patients will need, they'll need pressures of, 28 when they're not sick. They may end up needing even higher pressures during not so sick state, and higher need for FiO2 or mouthpiece ventilation, or if they need alarms or battery backup, then you initiate a home ventilator, is one of the expert opinions here in this realm. Um, I certainly tend to follow this. Sorry, as this to some degree, but there are other features, that I like, that that this does have an auto EPAP capability. And if I'm starting out with a patient who's already like Bob, who's already invasively vented, he already has a device. I think he came out with a initially with the Vivo, which at that time was not cloud capable. And so I just wanted to, or didn't have significant downloads in our region. And so I just felt more comfortable switching his device. And so this is what we switched him to a different device that was capable of providing me with auto EPAP and cloud data so we could follow him more closely. And the other things that made me make me often switch to these devices as if there's a progressive condition. We all would, it would be so nice if we could just see straight COPD patients, but that's not what we see. Is, we see patients with interacting disorders such as very severe OHS. I've had patients with BMIs in their 70s and 60s, and also patients with scoliosis or paralyzed diaphragm. So all of these overlapping conditions, and these are scenarios that are more challenging, that require higher pressure, more variability in the device settings over time. And those would have driven me to choose these other devices. So we've talked a lot here about the IPAP and what high intensity non-invasive ventilation involves. But I think here in this particular room, or in this particular Zoom, I think as most of us are sleep physicians, I think that EPAP is a forgotten pressure. It's the people's pressure that's important that we also need to focus on. So I thought we could spend some time talking about that. And there is some trouble we can cause with the TI. And I didn't spend too much time here because I really had something like 58 slides and I thought I'd go over time. So I'll go over EPAP for like a good several minutes. So we talked about auto PEEP and why it's bad. It's, or how it occurs, this hyperinflation, this trapped air, and it creates this mechanical load that patients have to overcome that pressure before they can initiate a breath. And so, we see it on invasive ventilators, on pressure control modes. And so the patient is trying to, changing from inhalation to exhalation here. The patient's trying to exhale and they're not able to completely exhale. And so it builds up this added flow still at the end of exhalation. And so over time, because that air is being trapped there, and there's this incomplete emptying or gas trapping here, there's a buildup of this pressure at the end of inspiration. I don't know if you guys see my pointer. Let me go back to a color. So this is what I was referring to at the end of, as people are trying to exhale, that volume is still, there's still volume left over. And because of it, this leads to gas trapping and leftover, volume. So progressive increase at the end of each exhalation of more volume in the lungs, leading to this term, this dynamic hyperinflation. And there's also a buildup of pressure at the end, which is this intrinsic plea. And so I think, auto PEEP can be public enemy number one for these patients, and it's not actually wanted. Big X over this poster. Nobody wants auto PEEP. And it makes it harder for patients to trigger the vent with ease. They have to work a lot harder. So, while ventilatory rest is important and we look to see, and this is something I struggled as I managed Bob because I just didn't know. My partner Kelly, if she's logged on, she'll tell you so many times that we looked at his download and we said, is this, are we seeing a lower number of patient triggered breaths because my auto PEEP is too high? And so the patient is not able to like overcome that, Or is he was so very poor BMI. He had lost all this weight after this. At some point he hit 14.8. Is it that the malnutrition, the degree of weakness, the hyperinflation contributing to it? Is it all of the above? And we had to bring him into clinic and watch his waveforms to understand what we needed to do. It may worsen dyssynchrony. If you're not, the patient's triggers are not being captured. I said Kelly's name, and there she is down the hall. It may worsen dyssynchrony because when the patient wants a breath is not when the device may be triggering it, if depending on what our settings are doing. And it also limits our treatment efficacy. The amount of pressure in the lung is built up. It may limit our ability to have the adequate tidal volume. I'm sorry, I'm talking too much here. I'll go faster. So the role of EPAP is to be able to adjust this. In OSA, as sleep physicians, we often utilize it for upper airway strengthening. And in a lot of sleep lab algorithms, we use it to eliminate like frank apneas. We use IPAP for hypopneas. In patients with COPD, adjustment of an EPAP may help with addressing intrinsic PEEP. It may pop that alveolus open and reduce the threshold needed to kind of initiate the breath. Going back to like this pink picture, maybe if we put some more air in here to allow that lung to not have to worry about the recoil of this airway first. And so we'll first look at, I'm sorry, I'm not able to see the top of my slide. I'm going to hit escape. The role of minimizing, what is the role here of minimizing EPAP? So we're looking first at the study by Sue, where 10 patients were evaluated with a ventilator that was capable of auto EPAP. And this may be the study where that used like the forced oscillatory technique to calculate like optimal EPAP. And patients were first started on an EPAP of 3 at baseline, and then they measured EMG activity. And they allowed that, so basically patient comes in, they have a mask on with connected single limb circuit to a vent capable of auto EPOP. And then they used a Respironics device just for technology reference. And they measured everything on an EPOP of 3. And then they allowed for auto titration for 45 minutes. So left the patient on the device to determine optimal EPOP. And measurements were then taken to evaluate like what happens when we go 2 steps lower than the optimal EPOP. And it's actually 3 steps higher than optimal EPOP. Pardon the typo here. And they measured diaphragmatic effort. They put in esophageal probes to measure this, and also intercostal EMG. And what they found is that, EPOP of 3 versus, which was like very low relative to the optimal EPOP, there was, greater degree of diaphragmatic like pressure swings, indicating patient effort. Pardon. There was greater degree of pressure swings and effort that the diaphragm had to go under with the lower EPAP relative to the higher EPAP. And then when we look at what happens with the optimal EPAP titrated by the device, going down 2 steps in the EPAP led to a higher degree of diaphragmatic effort or pressure swings versus going up on the EPAP further really didn't have that much more gains. And so, maybe it is something that from this physiologic study that it helps with diaphragmatic effort, right? But does this have clinical meaning? And so just to kind of review how this technology worked is that it used this forced oscillation technique to look for these choke points and use enough pressure to overcome that. And so this is a more clinical study that looked at either fixed EPAP or auto EPAP to see how does what we saw in that diaphragmatic effort study translate to our clinically relatable values, right? And so what are important here is to me, or it was this p-value column I was focused on, and the one that was different in both of these population is gender, so something to keep in mind. And the BMI was similar because to me as a sleep physician, I'm thinking like, well, is auto EPAP going to make a difference if you have comorbid sleep apnea? And I know like having the same BMI doesn't eliminate that possibility, but perhaps lowers it a little bit. The CO2 starting out was similar. And pardon, I can't see my last column here. Their FEV1 was similar. So in these patients, when they applied auto EPAP versus fixed EPAP, they had, I want to say T0 was like immediate, T1 was 3 minutes, and T2, the time to is 5 minutes in both of these groups. And what we saw is that over time, the auto EPAP group had higher elimination of CO2, and even at the end of 5 minutes had a higher elimination than the fixed EPAP. And when we look at what pressures were utilized, the fixed EPAP to some degree had almost a higher EPAP on average than the auto EPAP, and the pressure support, however, was higher. And so, it makes you wonder whether, is it helping us? I don't know that most of us routinely, for example, would have chosen a fixed EPAP of 8, but this group clearly did. I wonder if, using this method to give us greater confidence in the EPAP we choose allowed for greater pressure support in this patient group. And interestingly, their tidal volumes were also different and much more improved in the auto EPAP group. When we look at another study that looked at fixed level NIV versus auto titrating NIV, this is specifically in patients who do have overlap of OSA with COPD. So this prior group did not have OSA, it was just straight COPD, and this group is with OSA. So when we have what they looked at is, are there differences? And they found that really the things that seemed to be very similar were mean transcutaneous CO2 was similar. So was their maximum CO2. The EPAP in the fixed NIV versus auto titrating NIV was actually higher. And so it seems to matter when we have a patient population that has comorbid OSA as well. So, here's my editorialization of these settings, because maybe someday we'll have like more agreement on what settings we should utilize. It looks like there's at 47. And so I think, there is a danger in setting the IPAP too low, because we know that high intensity in IV, the high pressure supports the high IPAP made a difference. When we looked at that slide of various studies, I definitely now warned about setting the EPAP way too low, which we struggled for a while with Bob, finding the right EPAP. And, we didn't talk about this, but I avoid setting the respiratory rate or TI too high, because it'll worsen auto EPAP. And, be very careful, just because you see like lower percent of patient breaths triggered, what you don't want to be doing is then increasing the trigger sensitivity, which may then worsen their auto peeping. What are treatment outcomes that we should be measuring? What is and I just did not go through too much evidence here. I only went through the adherence piece very briefly. But, again, targeting normalization of CO2, but at least 20% from baseline. And the adherence seems to be maybe one study suggesting 5 hours at night, and also just improved quality of life and whatever we need to meet for each individual patient. This is one study that looked at patients with a COPD that were on NIV and showed how their outcomes, their adjusted hazard ratio for risk of death or hospitalization, based on how many hours of NIV they were utilizing, and their risk seemed to be lowest when they were in obese patients, among obese patients with COPD, when they were using it at least for 5 hours, but for non-obese patients, it really didn't seem to, there was no magic hour. For when they combined the data in a larger pool, there seemed to be, again, an effect around 5 hours. What else is new and exciting in this world that I continue to learn about is something called deventilation syndrome. I've had patients say this to me a lot, that, it feels great at night, but the second I take it off, I feel short of breath. And so there's a group that's studying this, and they basically showed that there's, by Borg, and it's not among all patients, particularly a consequence of high intensity NIV, is, they do have increased dyspnea, decreased vital capacity, and decreased 6-minute walk distance in these patients. What are the features that perhaps predict which patients will experience deventilation syndrome? For me, I kind of panicked when I looked at this table, because the TI, the inspiratory time was 1.42 at a max. And, some of the device algorithms, and a call out to ResMed is that when a patient doesn't trigger, we always find comfort in setting a range of eye time on those particular devices of like 0.7 to 1.2, like assuming the device will like know what to do, or 1.4. And if we don't specify, the RT will do it anyway from the DME. And when you have reduced triggers, particularly when a patient's in an exacerbation or auto peeping, the machine will always default to the highest eye time, which then will promote auto peeping because there's not enough time for exhalation. And so this was very scary for me. And I think we all now think in emojis. So I thought this was appropriate. These are some feature differences. And it seems like there, again, is a gender difference in patients to some degree, but the p-value was not very significant. So what are some strategies people are looking at out there? Something called pursed-lipped breathing ventilation, which, at the end of exhalation, it's not like they're prolonging the eye time, but the PEEP is kind of let down gently at the end of exhalation so that it may help, was the theory. And this particular study looked at patients that were established on NIV and were trialed on the pursed-lipped breathing ventilation, and showed that there was an improvement of the amount of pressure that was needed to maintain them without worsening I'm sorry, I'm just kind of pointing this out individually. I should have highlighted it yellow. The CO2 was not much worse when utilizing this particular modality. And so hopefully more data to come on this, because I think that's pretty cool and may help a subset of our patients. So what happened to Bob, right? And, I just want to call out to, Kelly Labruto and Dali Al-Daud, who are a nurse practitioner and a respiratory therapist I work with, who are amazing and helped us manage Bob and many Bobs like him. But I wanted to follow up on Bob's story. So we checked all these boxes for the things he needed. But then, there were some additional things we were able to do. How did we decannulate them? We usually, Dahlia calls them during the day and works on capping trials. And when they get to be off the vent during the day, they go on a VAPS AE mode, and we figure out what settings they need. And then once they're able to tolerate during the day, we move to the night and with the trach capped, and then we through a non-invasive interface, and then we decannulate them if they're able to not worsen their gas exchange. And so that's what we did for Bob. And he got to go home, and he stayed home. We met him when he came home, lived at home with his kids and wife for 2.5 years. He got his voice back, and it was so nice to hear it the first time. And he ate everything he wanted. And he saw his son get married back in May. And then he was evaluated for lung transplant. And I wish I could say that he got his transplant, but unfortunately, the very same week that um, he was seen, unfortunately, he passed away. Um, we are thankful for being able to take care of him. And so, there's a lot more that we could see in these patients. There's a lot more literature that needs to be developed, a lot more advocacy work that can be done as well. And, while I was thinking about what else could be done, all I could think about is more advocacy, more so than just fancier settings. So I just like to wrap this up by thanking everybody, just kind of highlighting 3 of the places I work. Thank you all again for inviting me. I'll take any questions.
Thank you so much, Dr. Naik, for a wonderful, patient-centered, data-rich, and very practical talk. That was just a great overview, really breaking down what's, I think, a very complicated and often underappreciated topic, that this is one of the things we can modify in these patients with chronic lung disease to improve their survival, that we don't often, my bias is don't spend enough time thinking about relative to inhalers and all the other stuff that we do for these patients. I am sure there are a lot of questions. I have several in the chat and I'll start reading them, but everyone should actually be able to unmute themselves now if they would like to put a hand up too. I'm gonna start with a question from Clara Yagi. He had asked, in the trials using high intensity NIV, what types of devices were used? I think you spoke about that a little bit after he had posed the question, but
Yeah. Most of the time, they utilized ST devices, and so ST devices have a higher pressure range. There's some that go to 25, but really some that go to 30 and some that go to 45. And so that's what they were using. And they almost always had a backup read, which we know from brand to brand, there's better regulation of eye time in some versus more autonomy in eye time regulation in some. So, but that's not what we are allowed to use by our payers, unfortunately, as a first line here.
Okay. And then Mayor Krieger had asked whether there are data related to the outcome quality of life in patients who have hypercapnic COPD and are placed on NIV.
So there is an actual improvement in quality of life in a lot of patients. But as we know, while studies demonstrate some improvement in quality of life, we all have patients, that proportion, that struggle to utilize the device, perhaps due to their sleep comorbidity or the dysynchrony that we create with the devices. And so there's certainly an opportunity to expand that outcome.
Thank you. Then there's a question from, or two questions, I guess, from Jyoti Lanka, who has asked, for patients with overlap syndrome, do you start with CPAP even if they have severe COPD with very low FEV1 and significant hypercapnia? Yeah, I'll leave that question.
Yeah, I guess it depends on the patient. Because I'm always thinking like what's gonna kill the patient faster. And sometimes I do think, it's not so bad here in our system when you are looking at just clinic referrals, but when you're looking at the larger scope of the population and how many patients that we ultimately need to examine, let's say if we're trying to go down the pathway of doing, to Dr. Lanka's point of maybe we do a sleep study and try to get them on the CPAP pathway. What is that experience going to be like for that patient? What are they going to be doing an HSAT? If they're on oxygen, maybe it's a PAP-based technology for testing or in lab. How long are they waiting? Are they likely to be readmitted during these times? How high is their CO2? What has been their experience with PAP? These are all things that go through my mind and determine a decision in terms of whether we focus on, getting them on PAP or NIV first.
Great.
And
Thank you. There are a couple more questions in the chat. I just want to also give people an opportunity to unmute, though, if anyone would like to ask a live question.
I'd like to ask a live question. Thank you very much, by the way. Your talk is very humbling for me. I've been away from pulmonary medicine too long in sleep. So what are the IE ratios generally? I mean, how much of time is being percentage of time is being spent in inspiration versus expiration, and 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 what what's the rates? I mean, when you get to a very high inspiratory rate, what's the respiratory rate on these patients? I know they vary, but what's the feel for that?
there seems to be this, in terms of choosing rate, it seems to be when you're in wake supine, whatever your respiratory rate is, the goal seems to be to often start with at least two less than that. But often the rate doesn't come down or is not supported well enough unless you're getting adequate tidal volume. And as our rate is changing, that then influences their IE ratio. And sometimes some devices, while they function within that range of what we set, again, depends on the patient's triggers. And also, it's a dynamic process because patients with neuromuscular disease have this slow progression over time, depending on their each individual disease state, whereas patients with COPD have a very dynamic process, frequent exacerbators versus not. And from really, some patients have such chronic, severe airways obstruction that emotion, simple sad dog movie changes their respiratory rate and their IE time. So I think the IE ratio is highly variable. And I am still learning about the freedom that some devices allow in patients to determine their own eye time. And I determined at one point in my life that that's horrible. I need to always control patients' eye time. And I struggled that with actually Bob. I switched him to a ResMed device, if I could use brand names again, because I want to control that eye time for every one of his breaths. And then I learned that it was causing too much auto peeping for him because I could never figure out what he wanted, and switched to a Respironics-based device, which allows that freedom, which I did not want in the first place. So I feel like I just answered it with more ambiguity. But I feel like it's such a dynamic process that we're still learning. And these are all the factors that I think about, what I want their IE ratio to be.
Thank you. I have one other question. I understand in auto EPAP in a sleep apnea patient what triggers the auto EPAP, but in a patient without sleep apnea, what how does that work? How does the auto EPAP know? How do they know how far to go up?
Oh my gosh, thank you for that question, because it's something I wondered myself. And it may be that each device has a varying algorithm. And those studies that we looked at, one of them used only Respironics technology, which used this force oscillatory technique where it's basically looking for similar degree, like just like our upper airways, when we're in sleep apnea patients, looks for that choke point and tries to overcome that pressure until that stops, until the choking essentially stops. Even in the distal airways, a similar process seems to be occurring. Whereas other technologies, we don't know exactly how they function. The I did not see in those auto EPAP studies a variability in various manufacturers, unfortunately. I'm reflecting on a total of 3 studies. Um, the deventilation studies did use, when they looked at who ends up with deventilation, used 9 different ventilator modes, ventilator brands rather. So unfortunately, I think we know from one manufacturer what they use. We don't know the answer for all, unfortunately.
Thank
Thank you
you.
so much. I think we're going to have to end here because of time. But thank you again to Dr. Naik for a wonderful talk today. And I just want to let everybody know our talk next week, you can see me looking up on my print on my wall here, is comorbid insomnia and sleep apnea. We are going to be hearing from Anna Krieger at Cornell, who had spoken with this group several years ago, but we're going to be glad to have her back next week. So we will see you then, and thanks to everybody for coming.
Hi, Maya.
Thank you.